With the last mini lesson that I posted, we were really looking at acute mechanisms of blood pressure control. Whereas here, what we're saying is we are moved past the minute to minute regulation, and we're now more concerned about how our body on a more long term scale works to regulate blood pressure. I think a really nice practical or clinical example of this is thinking about how diuretics are sometimes prescribed to treat blood pressure, right? So if you think about just lowering the amount of water going through our theoretical hose here, right? That's another way to ultimately control how much pressure is going to be on those vessel walls. So whereas before with the acute regulation, the tools at our disposal were going to be our heart rate. We could increase it with increased sympathetic activity. We could lower it with increased parasympathetic activity. We could control the vessel diameter. We could also control contractility, but we really talked about the diameter of the vessel and heart rate in terms of controlling short-term blood pressure. So here, it's all about the kidneys, and it's all about regulating our blood volume, which of course is a major factor in cardiac output. So I don't want you to think that we're stepping beyond that equation that we've seen so much, where we see blood pressure is cardiac output times total peripheral resistance. Those factors are still very much relevant. We're just going through different mechanisms to control them. So here with long-term control, we've got a direct renal mechanism, which essentially just doesn't involve hormones. And there's an indirect renal mechanism, which most definitely does. So with the direct renal mechanism, bear with me. So yes, it's independent of hormones, but ignore the figure for a second here. So if you were to think about turning up the quantity of volume that's going to go through our kidneys, our one of our major filtration systems, what we would see is that there would be less time. So if the blood pressure is higher, fluid is going to be going through the kidneys faster. And as a consequence, there's less time for the kidneys to reabsorb fluids back into the bloodstream. So more of that fluid ends up in our bladder. We end up making a larger quantity of urine. So if blood pressure is up, fluids go through our kidneys faster, and we actually end up creating a larger volume of urine. And so if we're excreting a larger volume of urine, then we are going to ultimately end up lowering our blood pressure. So that's how this direct mechanism works. And I've written it all out for you here. So if we increase the blood pressure or blood volume, it's going to cause elimination of more urine. So this is getting at this rate at which fluid filters from the blood. The kidneys have less time to reabsorb that, so more fluid leaves the body. So this graphic here, and from your text, is showing the reverse scenario. It's showing a situation where blood pressure, sorry guys, outside. So it's showing a situation where blood pressure initially falls. So blood pressure has now gone down. There's less pushing. There's less force on the fluids going through the kidneys. And so the rate of reabsorption is slower. There's more time for our bodies to reabsorb the fluids going through our kidneys. And so as a consequence, there's less urine that's formed and blood volume goes up. And so the direct renal mechanism is as simple as that. If blood pressure goes up, you make more pee. And if you make more pee, then as that feedback loop swings around, blood pressure ultimately comes down. Again, this picture here, blood pressure is initially falling. The kidneys are not filtering as much, so there's less urine that's made. And if there's less urine that's made, more fluids ultimately stay in our circulatory system, are going to stay in our blood vessels. And so blood pressure will ultimately come back up. We can definitely go over that one in class. So the indirect mechanism. So pause the video for a second after I ask this question. I want all of you to think. So in your mind's eye, name 2 hormones that we talked about way back in that first chapter of the class that are responsible or have some role in fluid regulation. So 2 hormones that have some role in fluid regulation. Pause. Come back to me. So hopefully ADH, right? Anti-diuretic hormone and aldosterone are the 2 main ones that were coming to your mind. So this is one of those figures that can be overwhelming at first sight, but when you start to break it down, when you start looking at the individual factors, I think it's a really good one at bringing everything together. So I'm actually going to start. So let me just highlight. So first of all, the initial stimulus here is a drop in arterial pressure. So our end goal, our end result is, of course, an increase in blood pressure. And so since we're dealing with long-term control, we know that we have ultimately got to get to an increase in blood volume. So that's what you're seeing here. Now, here's aldosterone. So aldosterone, if you recall, right, so it comes from the adrenal cortex, and what it's primarily going to do is it increases sodium reabsorption, and water follows salt. So if we're retaining more sodium, we're retaining more water, and blood volume goes up. If blood volume goes up, so does blood pressure. So that's this piece here where we're bringing in aldosterone. So that's really review. Here's anti-diuretic hormone, right? So coming from the posterior pituitary. And so this is saying it's an anti-diuretic. So if a diuretic makes you excrete more, then this is helping you to retain more. And that's exactly what we see. So water reabsorption. Reabsorption means that we are reabsorbing it into the blood. The kidneys do this, but when you see water reabsorption, you really want to think about that as fluid going back into our bodies, back into our bloodstream, which is going to increase blood volume. Okay, so this is the piece that we've already seen. So working backwards, we saw this in our classmates' awesome presentation on hypertension. And so we saw this exact mechanism. So it's oftentimes referred to as the renin, angiotensin, aldosterone mechanism. So again, working backwards, what causes aldosterone to be released is angiotensin, specifically angiotensin 2. So I'm not going to get I don't want you to get too bogged down here in these details. I'd like you to know that renin is a hormone that comes from the kidneys and that it's going to trigger activation of, ultimately, of Ang2 is typically how this is termed. So if you look, see the ACE? So angiotensin converting enzyme. So that group presenting talked about ACE inhibitors. And so what they're doing is they're blocking the conversion of Ang1 to Ang2. If you don't get Ang2, then you don't get aldosterone. You also typically or may not get ADH. And look what else it affects. So Ang2 simply just increases the thirst by your hypothalamus. If you're drinking more, your blood volume is going to go up. And then the fourth mechanism that it's going to influence is directly on the vessels. So Ang2 also is involved in vasoconstriction. So you can imagine how useful, how successful these class of drugs have been. They're not only working to stop aldosterone and reduce ADH, but it also has an ability to limit vasoconstriction. So a good test question that I could ask you would be describe mechanisms of action for angiotensin 2.